And we are now live. Chair Hopkins, you can proceed.
Good evening, everyone. Thanks so much for joining us again. Before we get going, we'd like to start with a brief message from Gilbert Martinez from our communication staff for our Spanish-speaking viewers. Gilbert?
Buenas noches y bienvenidos a la sesión informativa organizada por la Supervisora Hopkins y la Doctora Mase. Esta sesión informativa se está transmitiendo en vivo por nuestro canal de YouTube con interpretaciones al español. Para escuchar la versión en español, puede usar el link de YouTube que se encuentra en la página de Facebook del Condado de Sonoma. Gracias. Regresamos con usted, Supervisora.
Thank you so much, Gilbert. I'm Linda Hopkins, Supervisor for Sonoma County's 5th District and Chair of the Sonoma County Board of Supervisors. Welcome to our COVID-19 community briefing for Wednesday, February 3rd. Today, we're going to have a conversation, and it might be a tough conversation, about applying an equity lens to our vaccination rollout to ensure that the most vulnerable residents in our county are not left behind. Our plan includes targeted outreach to groups that work with low-income seniors, people who have underlying conditions, and the Latinx community, giving people with fewer resources a chance to sign up for a vaccination appointment before the system is open to the general public. We experienced this eager rush for vaccines last week with the rollout of our OptumServe clinic in Rohnert Park. While we intended this clinic to serve seniors 75 and older, the sign-up website soon became overwhelmed by people younger than age 75. We apologize for the rocky start to this pilot program, and we acknowledge the flaws and the frustration that it caused in our community. But we have solved the problem now, and we are targeting this vulnerable group for vaccinations before opening up the clinic to a larger group within the next few weeks. This would be a good point to remind you that during this community briefing, we will be taking questions live from the public. So you can leave your question in the comments area of Facebook Live. I also just want to remind our panelists who are joining us to try to speak loudly and slowly for the sake of our fantastic interpreters. I'd like to start by introducing everyone to our panelists who are here with us today. In addition to Dr. Mase and Dr. Shende, we have Alegria De La Cruz, the County Equity Officer, Barbie Robinson, the Director of Health Services, and Tania Candela, our Health Equity Program Manager. But we are going to start, as we usually do, with a brief presentation by Dr. Mase, Health Officer for Sonoma County, and Dr. Shende, our Vaccine Chief.
Great, thank you so much, Chairwoman Hopkins and everyone else, as well as everybody who's attending this briefing. Our case numbers continue to decline from the holiday surge. It is a positive sign, although we still are far from the end of the pandemic. Our new cases per day per 100,000 residents has dropped to 27.2. As a reminder, that number must be 7 before we can open more of our economy under the state's blueprint for a safer economy. Notably, though, we are close to the 25 new cases per day per 100,000 population required under the state guidelines to begin the reopening of schools. We have received reopening plans from school districts, and we're in the process of reviewing them to prepare for a return to in-person instruction. We're still in the most restrictive purple tier, which means that large gatherings are prohibited. With the Super Bowl coming up this weekend, I want to remind everybody that we've seen a surge in COVID cases after every holiday in the past year. This is largely attributed to gatherings. So for Super Bowl Sunday, we are asking people to avoid getting together to watch the game and instead consider virtual watch parties. We are progressing in the right direction, and we hope to continue to open and return to a sense of normalcy, but we have to remain vigilant so that we don't slide back into another surge of cases. We know that simple mitigation measures like wearing face coverings or masks, social distancing, and hand washing slow the spread or transmission of COVID-19, and we'll need to continue these measures until we're out of the pandemic, until a good proportion of our population has received the vaccine. We also continue to encourage people to get tested. Please go to socoemergency.org to find out about the testing opportunities that are available to you. There are no out-of-pocket expenses for these tests. Now I would like to turn this over to Dr. Shende to provide an update on the most important tool that we have to fight the pandemic. That is the vaccine. Dr. Shende?
Thank you, Dr. Mase. So as of today, the latest update shows that overall 50,532 vaccine doses have been administered in Sonoma County. The number of residents who have received their first dose is up to 31,192. The number of those who have received 2 doses is up to 9,670. The good news is that we have now provided at least 1 dose of vaccine to 10% of our population, adult population in Sonoma County, and 2 doses to about 2.5% of the adults in the county. It may not seem like a lot, but given that our vaccines arrived in our county only 6 weeks ago, and you have to wait 3 weeks in between doses minimum, we're ahead of the state average, and it's a number that's growing quickly. While we continue to offer vaccinations to all of those in our phase 1A population of healthcare workers, we continue to offer vaccinations to seniors 75 and older. While your primary care provider is the best source for most people to get their vaccines, the county and our partners continue to add new vaccination clinics to give people options to receive a vaccination. Please check socoemergency.org/vaccine for the latest update on vaccine clinics and how to schedule an appointment. The sites currently open or soon to be offering vaccines for those 75 and older include the Grace Pavilion at Sonoma County Fairgrounds, the Rona Park Community Center, serviced by OptumServe, Annalee High School, Guerneville School, Oakmont Burger Center, Huerta Gym in Windsor, Petaluma campus of the SRJC in Petaluma, Sonoma Veterans Building, and Cloverdale Citrus Fair, which I believe that they're going to be using the depot station, actually. Our hope is to start opening our vaccination opportunities to those 70 and older very soon. And we expect that we should get to those in the over 65 tier within the next couple of weeks. We also expect to provide vaccines very soon to others within the phase 1B tier, including teachers and food and agriculture workers. Our ability to vaccinate our population depends, as always, on the vaccine supply that we receive from the state. This week we received 7,425 doses, which is up from last week, but still not nearly enough to vaccinate everybody at the same time. We appreciate everybody's patience while we work through our vaccine distribution strategy, beginning with the most vulnerable. We'll talk more about this equitable approach to vaccine distribution during our discussion this evening. Thank you.
Thank you so much, Dr. Shende. Now, for the past few weeks, and really especially over this past week, you've heard that the county is focused on vaccinating people who are 75 and older. There's good reason for that. Seniors 75 and older have accounted for 2/3 of all of the COVID deaths in Sonoma County. These seniors are clearly vulnerable to the worst and most extreme outcome of COVID-19, death. And while we are committed to continuing to vaccinate these vulnerable individuals, we know that we also need to discuss, plan, and take action for those who face other negative outcomes of COVID-19. In reality, there's not just one group of vulnerable people, and there's not just one outcome that we need to consider. At the county, we're evaluating how people who have a higher risk of contracting COVID are those who are going to work every day to care for our children, to make sure that food makes it to the grocery stores, to make sure that food is growing in the fields, and other very essential jobs. These folks are also at risk for extreme outcomes of COVID, like severe illness that has long-lasting consequences, job loss, wage loss that can lead to homelessness. We know that many of these people who help keep our world turning in Sonoma County are Latinx. In fact, at one time, 90% of Sonoma County's COVID cases were in the Latinx population. So today, we're here to talk about how we can create an equitable vaccine rollout that prioritizes people who are most at risk for severe outcomes, including our seniors who have an exceptionally high mortality rate and those who face other forms of extreme outcomes. The conversation is nuanced. There's no easy answer, there's no right answer, and there are a lot of, quite frankly, shades of gray in between that we need to consider. But the wrong answer we know, and that is letting people fall by the wayside without focusing on how we can help and how we can come together as a community to protect the most vulnerable among us. I also just want to be open and honest with you guys, which is that, you know what, horrible doesn't begin to describe this. We don't have enough vaccines at the end of the day for our seniors. And I bet that you probably are either afraid for yourself or for someone that you love and care about. These are valid feelings. And now I'm asking you to go a little bit beyond yourself or a little bit beyond your family to consider groups of vulnerable people, because we can't wait to have these conversations and to protect those most at risk in our community. I hope that we can look at this as one Sonoma County family and that we can really think about protecting those among us who are the most vulnerable to negative outcomes of COVID-19. To start us off, I'd like to introduce Alegria De La Cruz, our County Equity Officer. She is someone who I believe it's safe to say that equity runs in her blood, it runs in her family, and it's something that she's been living and breathing and fighting for her entire life. I'm going to start off by asking you a totally leading question. What is equity? Because I think that we need to level set on equity. I think that we need to say what we mean when we say that, because that word gets tossed around a lot.
That is the question, Chair Hopkins. The county's definition that we're using right now to really say what equity means is our vision, right? That equity is an outcome where you can't tell the difference in critical markers of health and well-being and wealth by race or ethnicity. And we recognize that in order to get to that outcome, we have to have a process that explicitly values the voices and contributions of people of color, low-income communities, and other underrepresented and underserved people who have the solutions. They have the solutions because they've lived those lives to achieve an outcome that is truly equitable. And we know, because of what those stats that you've just shared with us, that we are experiencing deep inequity in our county. What is happening with regards to the COVID pandemic and the data of what has happened to our Latinx and Indigenous language speaking communities, that deep inequity is unacceptable. And what we have done as a county is to really operationalize that definition. We have recognized that our outcomes are significantly and unacceptably racialized. They're grounded in the fact that the great majority of our essential workers are Latinx and Indigenous language speaking. And we've asked members of those communities, of community-based organizations and of healthcare organizations, to help us find solutions that come from the communities themselves. And that's an equity design approach. And so using an equity design approach allows us to really help to shrink the gaps that can arise when the people that we're planning for, we need to really make sure that we understand and see them wholly, right? We need to design for somebody to serve that person who is non-English speaking, to serve somebody who's working maybe 2, maybe 3 full-time jobs, to serve somebody who does not have regular access to a primary care doctor, who isn't connected to regular internet or has other technology barriers. And our county's COVID response has really centered that person, right? We have centered those people because we've recognized the ways in which our systems, our economy, places those people at areas of highest risk, right? They have the riskiest jobs, they have the most crowded housing, they don't have safe and regular access to those systems that keep us healthy and safe, whether it's healthcare or unemployment insurance. And we are continuing that best practice as we roll out this vaccine effort. We've seen the concerns that can come, right? As the state changes its guidance for vaccine priority. When the state made that decision to add people who are 65 and older to the same tier that includes essential workers, that set off red flags of inequity. And those red flags are grounded in real concerns. Although low-income communities of color have been hardest hit by COVID-19, in many areas, including our own, people from wealthier and largely white communities flooded our vaccination appointment systems and took an outside share of that limited supply that was really dedicated to specific populations. And so what we're doing right now is really making sure that, we focus on exactly those populations that you have identified as having multiple areas of vulnerability to this disease. That shift made it so that people who are working essential jobs may not receive their vaccines as quickly. And some of those people are also themselves between the ages of 65 and 75. So while we are definitely dedicated to making sure that we want people who are most at risk of getting COVID and having extreme outcomes, like those over 75, or like the 45-year-old who is going to work with underlying conditions in a risky situation, we want both of those communities to receive vaccines. And what that means is that somebody who's in their 60s and who may not have underlying conditions and who has the ability to stay home safely, we're asking that person to wait a little longer for the vaccine. So as we develop a prioritization system and as we recognize those real logistical barriers to many of our essential workers that they will face as they try to sign up for vaccines, right? Technology, transportation, the luxury of time. we're going to make sure that we address those concerns, that we design our system and prioritize our system that really centers that kind of person in our system, and make sure that we are lifting up those folks and that we are designing our systems around them. There are positive changes on the horizon. The federal government has moved forward and issued an executive order and established a task force to address equity. And Governor Newsom is working on the next phases of the vaccine rollout. So we will have support and some guidance to navigate these difficult decisions. At the same time, we know that we can't wait for how that shakes out at federal and state levels. It took 9 months of this pandemic. It took incredibly high rates of infection and transmission among our Latinx and Indigenous language speaking communities. And those without access to important resources. It took a long time for the state to begin really tracking equity metrics during the reopening process. And we saw the toll that took on communities who did not have the resources to really carry that burden. So I'm gonna wrap up with just this thought. We have an opportunity and we have an obligation to really take a close look at the level of control and discretion that we have in the County of Sonoma to make sure that our vaccines are equitable and that we do everything we can to get those vaccines to the people who most need them.
I really appreciate hearing your thoughts, Alegria, and I look forward to circling back to you. You know, one thing that I think was really critical that you highlighted was the logistical barriers that folks face. I mean, I've heard of people traveling, 5 hours out of the county to get a vaccine as part of another healthcare system. I actually heard today of someone flying to Florida to get a vaccine. I mean, do you just want to touch on sort of, almost like person A and person B, right? And the barriers that they might face in trying to get a vaccine if you're juggling 3 jobs compared to if you can stay at home and, be kind of more in the know and have access to technology. Do you have anything else to add on that?
Sure. I really ask people to kind of hold in their minds and in their hearts, a population that we're particularly concerned about right now, which is H2a workers. These are visaed workers who come from other countries to work in the fields of California. They are not from this country. They're not familiar with our systems. They certainly don't have access to primary medical care that's easy. They don't have transportation beyond that which their employer provides them. They live in congregate housing. They do not have the ability to distance from each other. They're usually transported together. And so I think about that person, right? And the ways in which we really need to consider somebody who doesn't speak English, who's not from this country, who is not familiar with these systems, who does not have the ability because of the work that they are doing right now to follow all of the guidance that we know will help them to prevent infection of COVID. And so those are the folks that we really need to figure out, how do we really design our process and prioritize their vaccination, given all of those risks that our systems created for them. And so, if our systems create those risks for those people, then the system that addresses how to reduce those risks also really needs to take into consideration all of those different characteristics of that person that we're holding in the center of this process.
I really appreciate that. And I think that understanding the systems that we're working in and also their potential failures and current failures is really critical to identifying that path forward. Before I ask Barbie about next steps, I'd like to really quickly highlight just one of the important components of vaccine distribution. And that's where Sonoma County fits into all this, because I think there's been a lot of confusion around this topic. So quickly on distribution, the CDC actually sends vaccines to the state as well as to pharmacies like Walgreens and CVS, who are vaccinating our long-term care facility residents. The state then in turn distributes vaccines to multi-county hospitals like Kaiser and Sutter, and then counties who deliver vaccines to local healthcare providers. So the county itself is not actually administering any vaccines because we don't have a county hospital. Right now, as mentioned earlier, the county has adjusted the state's prioritization guidelines to only include people who are 75 and up instead of 65 and up. But that's only for the OptumServe vaccination site, which is being managed by the state. Many clinics are still vaccinating healthcare workers, and hospitals are still prioritizing their patients to the best of their ability. So that's all to say that every move we make must be closely coordinated with partners, and that there are many decision makers at the vaccine table. And I really hope that we can make sure that each and every single person at that table, representing every single entity involved in the vaccination process, is centering equity as well. So with that context in mind, I'd like to turn to Barbie Robinson, the Director of the Department of Health Services. I'm wondering if you could tell me what the next steps are to creating a more equitable system for distributing vaccines.
Yeah, and with that, I really want to honor and have Ms. Denia Candela, our Health Equity Program Manager, speak to our equity framework and how we're operationalizing it in our COVID response.
Thank you, Barbie. Definitely with the overview and how important our partners is right on. We're cogging the vaccine wheel, and this is the first of our briefings on equity. So next time I look forward to having some partners on the virtual table to really be able to join that discussion as well. For right now, I'll really focus on where Sonoma County is as a whole stands on our vaccine equity efforts and how we're going to move forward. As Alegria mentioned earlier, we rolled out our attempts to really use our vaccine equity strategy to ensure it built into our vaccine operations. Our overall strategy really includes providing transparency in the science and the vaccination process. And again, prioritizing those who shoulder the most at risk and including culturally responsive practices through this implementation process, while at the same time being able to acknowledge the negative impacts and painful history that our healthcare systems has had in communities of color that really have led to the distrust of the research and government entities. We plan to engage more with community stakeholders to really grasp and have a better idea of their concerns and what those needs are. And above anything else, really learn and improve as we go. One of the ways in which we're really putting this into operation has been in the ways we are making sure our partners and those who are receiving an allocation from us are adopting our vaccine equity framework, like Barbie mentioned earlier. This is going to make a difference in the lives of our residents who are the most at risk of contracting COVID-19. So we're taking in consideration location for anyone who's organizing a vaccine clinic in Sonoma County. The sites can be easily accessible and located in neighborhoods where people live. We can meet people where they're at. And we're considering also an integrating community component because we acknowledge that people of color are historically untrusting of government, means that we're going to work twice as hard to share this information and why this vaccine is safe. We are committed and we ask our partners to commit to caring for the whole person who should have to receive a vaccine. That means having resources on site as well in a culturally responsive way. We're also working really diligent and around the clock in ensuring that we have staffing who has bilingual and multilingual, as well as Indigenous language speakers, multicultural staff that are available at vaccination clinics to share information in the language and so they can be able to provide support and better understand this process. We are aware of the different organizations in the county are receiving vaccines from various entities and that everyone in different ways of getting them to the community. We're going to ask of all the clinics to receive vaccines from the county to follow up this equity framework. And of course, any use of the county's vaccine supply will follow this framework as well.
Thank you so much, Dania. And I think I want to get to the question from members of the public, but I do have a question that I want to ask, and this one's out of left field, so I'm not going to, this isn't going to be a softball one. Do you think that social media and sort of the internet actually exacerbate inequality? And I ask that because what I saw happen with the OptumServe site was that it went viral, but it went viral in a specific way where I saw, actually some, affluent and influential community members sharing it with their email list, sharing it with their social media circle. And so, it kind of went almost like top down, from some of the people in our society who perhaps were actually least vulnerable, right? Folks who work from home, folks who can, afford to have a good healthcare plan and an established primary care provider. So, my question is, great, does social media and the internet and also our reliance, quite frankly, on online appointment scheduling exacerbate inequities in the system? Y'all are being too quiet. Someone jump in.
No, definitely. I would say yes, Supervisor Hopkins. That absolutely does completely in agreement with that. When we think of social media and in the ways and the right approach to reaching these communities, social media definitely doesn't play in our advantage. I think we learned from the neighborhood testing, right, that a lot of it was word of mouth, and we were able to reach communities, to those really stakeholders who have that close connection to these communities, like family resource centers. That was really the way of spreading the word and ensuring that we did have the people that we intended to reach get to those testing sites. So we plan on those in a similar way to do the same with vaccine clinics, but social media was not our friend this past time around. You're absolutely right.
What do you think, Alegria? And how do we overcome that, right? How do we swim upstream or counteract that sort of, people who are in the know, right? Get the word first and then book the appointment.
Yeah, I want to just acknowledge and thank our community partners who made sure that they knew. They told us, don't do it this way. So we knew that, and we've been developing a different way that's really in line with those lessons from our communities. So, there are trusted voices in our community that spread that word much more efficiently through low-income communities of color, through Latinx and Indigenous language-speaking communities, much better than a Facebook post does, much better than an email does. And we also just want to, again, thank and recognize those community-based organizations and those community leaders who have played a critical role in spreading that word and getting those voices and getting those, and literally helping people type their names in and checking the box, yes, I qualify as an essential worker, and making sure that we are making true on those promises to our communities that if you qualify, there's a place for you, right? And making sure that we help people really access those systems that can be very difficult. It's hard, I think, for those of us who spend the majority of our days on Zoom and texting each other incessantly, to imagine a world in which that is not somebody's reality at all. And so again, just really relying on, the skill set, the connectivity, and the voices of those community members who have been instrumental in making sure that that we are able to reach those folks that we all know we will miss without them. So just a big, huge shout out and a huge thanks to our community leaders who have really helped us do our jobs in this moment to reach those folks.
We are really lucky, and it was amazing that we had, volunteers and staff and nonprofits all making personal phone calls to some of the most vulnerable members of our society. So my last ask to the community before handing it over to Paul for the live questions is just, if you know someone who's over the age of 75 right now, call them. Find out if they have their appointment. If they're struggling to figure out how to book that appointment, help them, walk them through it, do it for them. And similarly, if you know someone who is less advantaged than you are, reach out to them, check in, find out where they are in line. Maybe they're older than you think they are, and you want to check in and just make sure that they might be eligible. I think that there's maybe a new polite way of asking for someone's age if you're offering to help them obtain a vaccine. So with that, I will hand it over to Paul for questions from the audience.
Well, thank you all. This is a really important discussion, and we appreciate you all being here. We do have quite a number of questions from our viewers. Let me start with, we'll concentrate on the ones about kind of some of the equity things we were talking about. One of our viewers asks, what is the plan for folks who don't have access to computers or internet? How do we get them signed up for these appointments that we have set aside for them?
I think the best person to speak to that is Denia, who has been spending almost every waking hour making sure that every single person in our county has a functional link to how best to do that. So Denia, go ahead.
Yeah, thank you for passing that on, Alegria. I think we can say honestly that we have an equity framework in mind, and that we're working towards ensuring that every person in our county does have access by picking up the phone and hopefully calling, right? And we're definitely getting there. OptumServe does have a phone line now available, and we are yearly going to be sharing as more of our clinics have more access to these phone lines and an actual person behind on the other side of the phone. And Ken has also been working really hard to connecting with these partners to ensuring that there isn't a human on the other side, that there's able to address these questions that people are signing up.
If I may just add to that, we're learning. And so I think going forward, we will start to have information available on the website as to whether one can register on site whether one can put a phone number if available to make calls that way so that people have more options. We will definitely work on that because we're learning step by step.
True enough. Thank you. Diana from Facebook asks, how will Sonoma County know when all of the people over 75 who want a vaccine have been vaccinated? Also, what % of those are in long-term care facilities and already have been vaccinated? Do we have those numbers? Dr. Shende, do you want to take that on?
Sure. So for the first question about how will we know when everybody over 75 has been vaccinated? This is going to be a fluid process, and we're going to keep moving through it. We will start to collect data. We've just started doing the over 75 group. We will continue to collect data as time goes on. We're only about 7 to 10 days into that age group. As far as these skilled nursing facilities and the RCFEs, at this point, all of them have received their first visits. There are a few that are left that have actually asked us through partnership with Kaiser to actually go in and do their first appointments because they were delayed. But at this point, we've reached the majority of the skilled nursing facilities and the residential care facilities. I don't have those numbers in front of me, but we've made good progress. A lot of them still need their second visits.
Great. Stephen asks a basic question. Are we officially in phase 1B, tier 1 now?
Once again, everything is fluid. So we are in phase 1B, tier 1, in that we are vaccinating our over 75 population. So that part has, yes, definitely started. That being said, we still are finishing up with phase 1A. There still are some healthcare providers and in-home service providers who we are trying to reach. So again, it's a fluid process. These are not rigid tiers, and we will continue to move forward.
Again, really good questions from our viewers this week. Mike asks, and maybe this is one for Dr. Mase, there has been a dramatic drop-off in COVID cases over the past week. Is this due to vaccinations starting to make an impact? What do you think?
That's actually a great question. Certainly, vaccinations may have had some impact because we know that our healthcare workers, people that are in phase 1A, tiers 1, 2, and 3, many of them have actually received the second vaccination. So certainly it may have had a small impact. I actually think that the stay-at-home order that was put into place in early December may have had an impact. We were about 6-7 weeks out from when that started. Actually, I guess close to 7 or 8 weeks at this point. And that may have had an impact as well on a decrease in cases.
And we're certainly getting farther away from the holidays too. That certainly helps. But as you said,
yeah, I mean, we see less travel now than we did in December and early January. We also are seeing less gatherings because we are past the holidays. So I think it's probably a bunch of different things that are leading us in the right direction now.
So Ali asks, why are we not following the guidance from the state? She says, we are supposed to be on 1B, which includes everybody 65 and owner at the same time as we vaccinate essential workers. Why are we not following the state guidance on that?
Every county has its unique situations. And for Sonoma County, our situation is that we have a very sizable population over the age of 65. That number is 102,000. It's 25% of our total population. Our vaccine supply, as we know, is extremely limited. We are getting a trickle every single week of vaccine, and that forces us to have to prioritize in a way that makes sense. So over the next few weeks to months, as the supply starts to increase, then we will be able to expand our tiers. But at this point, we simply do not have the supply. We don't have the vaccine supply to be able to reach all 102,000 people. So, and the state recognizes that, and they have given the counties some control over what they can and cannot do, realizing that every county is going to be unique.
Great. We actually have a viewer from YouTube who has a question. Euduro Avia asks, he notes some people got their first vaccine at Roseland Library and were not told how they get their second vaccine, and the time for that second dose is coming up. What should these people do?
I can jump on here. We are working right now and reaching out to folks that were part of the Roseland Clinic for the promotores and promotoras, and we will be reaching out to schedule that second dose. We're in the process of making that happen.
Great. Thank you, Denia. We also have someone who asks, they would love to know information about if there are volunteers out there who are driving seniors to medical appointments and or delivering meals. Do we know, and I guess whether there's a place you could sign up to help with that?
Yeah, that's a great question. I would follow up with your local senior center or perhaps your family resource center, your FRC. There are so many people who've reached out who want to help us. And it's been a challenge trying to connect the huge numbers of people who want to help. So I think in terms of driving seniors around, it would be good to reach out to those locations. And we are actually going to be in touch with them. We have been already through our push to try and get more over 75-year-olds in. But over the next, actually tomorrow, as well as over the next week, we're going to be more in communication with them. And so I think the best way to try and volunteer in that respect is to reach out to your local senior centers.
Okay, we're going to turn to some of their questions from our media partners. Dan from KRON Channel 4 asks, how many doses do we receive each week to the county? And is that weekly vaccine supply staying about the same, or is it going up?
So every week it's different. Every week on Tuesday night, we can't wait till 9:30 rolls around because that's when we are notified as to what our vaccine allocation will be from the state. Every week it's different. There were a couple of weeks where it went down, but thankfully in the last couple of weeks it has been going up. So on average, we've been receiving about 6,500. This week it's a little bit more, about 7,000 doses of vaccine. That being said, our capacity for distributing these vaccines to partners who then administer the vaccine has increased as well. So at this point, our capacity is in the range of about 7,000 to 8,000. So it's pretty equal. We are starting to make more vaccine available in the community as the supply very slowly starts to increase.
Okay, great. Let's go to Martin Espinoza. Martin had submitted some questions in advance. I don't know if you want to just ask them orally, Martin.
Can I ask that on my second round?
Yeah, sure.
I want to stick to the equity issue because I think it's a really great discussion, but I think something is really missing here, and that is data. I was just looking at the Florida Department of Health, and they have a lot of data. For example, in Broward County in Florida, Blacks, African Americans have been who are about 27.7% of the population, have only received 8% of the vaccine. Hispanics, who are 30% of the population, have only received 14% of the population. So I know that this data exists because the state told me that they're trying to get it up on their website as soon as they have the resources to do so. I don't understand why California is taking so long, home of Silicon Valley. But can you tell us, and I hope you guys give me this information, but can you tell us what the demographic breakdowns right now are for the vaccine that's been administered?
I don't think we have those numbers in front of us right
I
now.
think, Paul, we actually need to go to Kate Pack, who's our lead epidemiologist. We are trying to get that data up, and Kate, if you could respond to that, that'd be great.
Sure. Yeah, so Martin, we're actually working with GIS this week, working on getting up the demographic information on our website. We are tracking age gender, race, ethnicity, and geography of doses administered. On our data dashboard, we will be posting the characteristics of residents who are fully vaccinated, so those who have received 2 doses. Right now, when we look at that data, it largely represents the demographics of our healthcare population because those were the folks who were prioritized first and compose most of that group who have received 2 vaccines. When I last saw the figures this week, I believe it was 7% that was identified as Hispanic, Latinx, 32% unknown, and 61% non-Hispanic. Yeah, oh, thank you for bringing that slide up. But again, I think these are going to be important metrics to track ongoing, particularly as the vaccines open up more to the general population to make sure that that we monitor that reach. And if you would like, Martin, I can also share one of our FE team members is running that data again today, and it's going to be providing that to me. And if you would like me to provide you a snapshot of that before that goes up on the dashboard, I would be happy to share that.
That'd be great. Thank you so much. And as a follow-up, you know, I guess if you could, Barbie and others, Supervisor Hopkins expressed sort of the desire to have more information, more coordination, more cooperation, more transparency, if you will, around the vaccination efforts of some of our large healthcare providers. And you know, then Barbie mentioned that the state is actually proposing a third-party distributor for the vaccine, which would be Blue Shield, and I think in conjunction with Kaiser. And I was hoping to get the county, Barbie, Supervisor Hopkins, to comment on how they feel about that. That seems to be going away from what we're calling for here, and that's more involvement from the county rather than less.
Thanks, Martin. Great question. It's my understanding that the state will be releasing the contract for the third-party administrator on February 15th. I do not know what's in that scope of work. I know that health departments through our association, we have association, has been expressing concerns with the administration on behalf of local jurisdictions regarding, needing more information and how that third-party administrator is going to coordinate and collaborate with local health departments in terms of their processes. And, we were told to move quickly to ramp up, and local health departments have relationships, have partnerships, and we're just unclear how those partnerships will be utilized or honored through this new third-party administrator proposal. And so we do have some concerns because we know best at the local level how to address equity, what are the trusted partners in the community that can help support ensuring wide access to populations that are underserved and typically have challenges with access to healthcare. And so we do have some concerns, and we, continue to lobby and advocate to be a part of the process in better understanding that relationship.
Thank you.
I agree with everything that Director Robinson said. And, I will say that many of those kind of sole source or, just go straight to the provider contracts have been really problematic. I mean, you guys did a great job of covering the challenges with the skilled nursing facilities and the slowness of the rollout there, and what is just a very, very vulnerable population in Sonoma County. The other thing that's frustrating is, of course, that, this is 2 weeks out and we don't know what it's looking like, and there's no details or no information. And so, there's a lot of apprehension over, are we suddenly going to be mandated into a system? Is that system going to be functional? Because we already know that there, have been challenges with implementing other state programs. So yeah, there is a lot of concern. And there was a pretty amazing letter that went out late last week where you actually had the urban counties, the rural counties, the health directors all lining up to express reservations about this process going forward. So
And if
at the
I
end of
may
the day, I think that Denia and Alegria spoke really well to the fact that it's our local providers who have those relationships, who know who by name the vulnerable members of our community are, right? Who are trusted by those members of our community. And so, you know, as frustrating as the fragmented system has been, there's a little concern about, is this going to be trying to be a one size fits all solution? Will it be culturally competent? Will it be customizable for different counties who have different populations and different, you know, priorities and different concern areas and different outbreaks in certain areas? So there are, you know, as usual with state announcements, more questions than answers at this point. Director Robinson, did I miss anything?
Yeah, no, I was just going to add, Chair Hopkins, I really want to emphasize that it's unclear to us what this third-party administrator contract is going to solve. You know, we're unclear of what the problem is specifically that they're trying to solve. And for us, the biggest issue is the lack of supply. I cannot emphasize that enough. That is really the crux of the challenge that we have. We have ramped up despite having a fragmented system and built coordinated across our healthcare delivery partners. And we're really waiting for vaccines. And I think that's really would, you know, give comfort to the community if we knew we had adequate supply to work our way through those tiers. And that's really the biggest challenge. But it's not clear if that third-party administrator's role and scope of their function is going to be to resolve that challenge.
Thank you.
Okay, thank you, Martin. Let's go to Phil Barber. Phil, you there?
Let's beat the Optum serve dead horse just a little more if we could. Obviously things got messy there and a lot of appointments were wiped clean by Optum Serve before they started reinstating them. I'm wondering, do you know if any doses wound up going to waste during that process? And if so, how many?
This is Ken Tass. If I can answer that question, the answer is 0.
Great. Ken, do you know how many appointments ultimately were vacated? We heard that there were 9,000 appointments by people who weren't eligible. Were those all slots that wound up empty and having to be refilled? And do we know how many went unused basically on those days?
The short answer is, remember that while 9,000 appointments were canceled, generally there were double appointments, first and second appointments. And so it was approximately half that many individuals that were impacted by it. That being said, I know that the appointments, the very next day, as soon as we opened up, those over 75 refilled those appointments. I was on the site that next day and on on Tuesday when they opened, and all the slots had been filled. And I can report to you that a number of the seniors that were over 75 that were there said, "Thank you very much. We couldn't get in because all the slots were taken. And when you made them available, I was then able to get in." And I got numerous reports from staff on site that happened.
Great. I also have some other questions, but I know time's limited, so I'm going to let some other people jump in too.
Thank you, Phil. Let's go to Camille Escovedo. Camille?
Hi, my question is, can you hear me?
Yeah, we hear you fine.
Okay, thank you. What are some of the main approaches that the county is taking to do outreach for older and elderly Latinx people and Indigenous community members? Like, what are some of those methods? And I'm also curious what organizations are being utilized to get to those people in person.
So that's a great, Danielle, you want to take that?
Yeah, I can answer that question. We definitely have relied, like what we have said before, community-based organizations to do this outreach. We did have a partnership with the Aging Division as well, and I'm connected with those trusted partners. Family resource centers across our supervisorial districts, we connected with them as well. Burbank Housing, addressing our low-income seniors. So some of those organizations are part of it, but also just recognizing, like Alegria mentioned earlier, our CBOs and those grassroots organizations that really helped us spread the word and get these people signed up were also part of this process and part of the outreach plan.
I would just add, Camille, that the county's COVID response, under the leadership of Director Robinson, popped up the Latinx Health Work Group, made up of community-based organizations and community leaders to really help the county to dive down deeper into that community and into those really important cultural assets that exist within those communities and to activate them. And so we are so glad to have that group that is really continuing to be, trying to drive those messages deeper into these communities. The same challenges that led to those communities being at high levels of risk for COVID infection are the same challenges that lead to those communities being at risk for not being vaccinated. And so, you can really see the ways in which using an equity approach in the emergency response continues to support using an equity approach in the vaccination response. I would also say that, the county is figuring out, we had a very successful community clinic in the Roseland where we vaccinated promotores and promotoras, and making sure that we are continuing to recognize the power of community promotores and promotoras to share that word with the people that they serve every day, with the people that they speak to every day, about what the vaccination process is, as well as not letting up. COVID isn't going away, right? We still want people to get tested. We still want people to make sure that they are maintaining as well as they can distance and masking and not hanging out with each other as hard as it is in month 11. So we are continuing to rely very heavily on our community partners to continue sharing that information.
I was wondering also if I'm so sorry, Candela, if you could describe the tenets of the equity framework.
Can you repeat that question?
Oh, I was curious, looking for a bit more detail on this equity framework.
Right, so our vaccine strategy involves multiple components to achieve an equitable vaccine rollout. And within that vaccine strategy, there is pieces of the equity framework. So what it really looks like to do equity when you're actually putting up a vaccine clinic. And that means that the county will be looking at geographic equity, distance between testing sites and vaccination sites, having and asking our partners to think about, whoever's implementing this vaccine clinic, to think about having multilingual speakers on site and multicultural folks on site. So all of those things are important in the way that we're rolling this out.
Okay, let's go to Megan Goldsby. Megan?
Hi there. Thank you for taking my question. I have a quick question about testing. It's quite the contrast at the fairgrounds right now to see the line to get a vaccine and then no one going to get tested, almost no one. And I know Dr. Mase, on Monday, you said we really do need people to keep getting tested. Is there a metric that the county gets additional, bonus points towards moving tiers if we do more tests, or is it all about the ratio? Why do we want people to continue to get tested?
Well, the vaccine has not gotten out to more than 10% of the population. It's been largely the healthcare workers and people in the phase 1A that have been vaccinated. So we definitely want people to continue to get tested because that allows us to find those people who are cases quickly, get them isolated, prevent further transmission, get their contacts identified, quarantine tested. So the whole process is still going on from the county. So it is important to get the word out that even if you're asymptomatic, if you're concerned in any way that you may have been exposed to somebody with COVID, if you've been in a group or gathering that you're concerned about, the schools, for example, as we move towards opening schools, there'll be surveillance testing. So I think there's a lot of testing that still needs to occur. The demand is less. And I want to encourage people to get out there and get tested to the extent that you can, because it will help with our numbers as well. Right now, I believe that we're doing about 600 some tests per 100,000 per day. And we really want to reach more, like 800 tests per 100,000 per day to get a good correction factor for our cases per day per 100,000. So just go ahead. We have plenty of ways you can get a test. Go to socoemergency.org, look for where you can get tested, make an appointment.
And I understand the most important thing is to find the cases. The correction factor that you mentioned, could you just very quickly, last question, explain how that works? So the more tests we have, the better chance we have of moving tiers?
Right, so there's a state average for testing. Taking all the 58 counties in California, it looks to see how many tests per 100,000 persons are being conducted per day. And if we're above that, we get a favorable correction factor for our case rate. So for example, 2 months ago, a month and a half ago, we were doing still about 600 tests per 100,000 per day, but we had a multiplication factor of 0.5, meaning that our adjusted case rate was half of what it actually was. That counts towards our blueprint tier. Now everybody's testing a lot more, it seems, so the state average has gone up. Therefore, even though we're still testing over 3,000 tests a day, our multiplication factor is now 0.8. So if we can test more people, the state rewards us by giving us a multiplication factor for the cases, number of cases per day per 100,000, which then determines what our tier status is. I hope that makes sense. You can go to the state website to see exactly what the numbers are in terms of the multiplication factor.
Thank you so much for explaining that.
Excellent. Okay, we're going to be wrapping it up soon, but Phil, you had another follow-up, one more?
Thanks a lot. I appreciate that. Different subject, talking about the variance in the age standard in the county as opposed to the 65 and over at the state level. Totally understand your reasoning when it comes to equity and a vulnerable population over 75 when you look at the numbers here. But I'm just wondering, and this could be for Dr. Mase or Dr. Shende or whoever is appropriate, but even with the logic behind that, when you see the complications that have resulted, OptumServe being the biggest example, is it worth it? Is it worth striving to serve that vulnerable population when it's causing hiccups like we're seeing?
I think it's absolutely important to always do the right thing. And what we are doing from the county perspective is to protect our most vulnerable population. We want to prevent hospitalizations and deaths. And that clearly from the data and the data-driven perspective, we need to target those people most at risk, that's 75 and over. So the hiccups are there. It's a very hard process. We understand that. We apologize to everybody who's been put out as a result of the process, but keep in mind that we have the community's best interest at heart. And we are protecting the most vulnerable population from the worst outcomes, which include death.
And then, I'm sorry, just one last follow-up to that. You've talked a lot about the fatality rates amongst the 75 and over population, the very high percentage of fatalities in the county coming in that age group. Obviously, it's also true that that age group makes up a higher proportion of people living in the long-term elder facilities, the congregate settings, which are so at risk. Do you have data? Do you know that if you separate out the care facilities, are people 75 and over living independently more at risk than people in the 65 to 74 age group living independently?
That's a good question. I'm not sure we have that data, but I will ask Kate Pack to weigh in on that to see if we do have that data.
Sorry, trying to unmute. Well, looking at our cases that we've seen among the 75 plus population, we see about a third of those were residents in congregate care facilities, but there was also another third where that information wasn't in the case file. So I can't kind of speak definitively that all of the remaining folks were living independently. But I know from the data on our cases, it was about a third that were in congregate care that it was documented in the file.
Okay, well, listen, this is a great conversation. I appreciate all the answers. We are at the top of the hour. We're over the top of the hour, but thank you for your answers. And I'm going to pass it back to Chair Hopkins.
Thank you so much, Paul. And my commitment is that this might be the first discussion on equity, but it will not be the last, because equity is not something where you just check the box and move on. This is something that you have to keep actively working at every single day. And so that is what we're going to keep doing with respect to the vaccine implementation. I just want to thank so much all of our panelists for joining us today, as well as Jordi, our Spanish interpreter, and Naomi, our ASL interpreter. I just want to remind everybody that you can always find the most up-to-date information on socoemergency.org/vaccine. You can also follow us on Facebook and Twitter. So we will be back here, same time, same place next week. So take care, everyone. Be well.